Case of complex total occlusion, chronic total occlusion. You can see here exactly at the ostium is the beginning of the occlusion, and the segment totally occluded is around 3 centimeters, 3 to 4 centimeters. We know from previous angiography that this segment has some difficulty, anatomical difficulty, because there is some tortuosity here before the bifurcation. So we started with 7 French guiding catheter, antegrade approach. In these cases, even in the presence of good collaterals, I would prefer going with an antegrade approach. And starting with dedicated wire, that means we started with Miracle 4.5, just to test how much is the difficulty here to cross the lesion. And you can see here we advancing a bit in the proximal part of LAD, but you see that the distal point of the wire is going to side branch, that means one of the first septal branches. And again here you see the wire is inside the septal branch. The right direction is a bit tortuous here soon after the origin of this septal branch. So what we decided here after several attempts is to leave the wire here and to go with a second wire in order to be able to orientate the wire toward the right direction. Here the wire left here in the septal, and you see now the second wire is oriented toward the LAD. This is the LAD course. Here we can advance the wire now in the LAD with a balloon support here, but we were stopped just beyond the bifurcation because there was some difficulty, very solid material inside the cornea and some calcification seen also in angiography. So at this point I decided to go with to change the wire. You can see how many multiple projections we took in order to be sure that we are going in the right direction. And now I went with Conquest Pro. And the Conquest Pro in this kind of cases, when you have such a difficulty to cross the total occlusion, I think is the best solution. Again, you see now we have crossed with the Conquest and with the balloon support here. Now we advanced in the patent segment of the artery, that means distally to the bifurcation. You can see how easily now is crossing and traveling this, navigating this wire inside the LAD. After crossing, I think the case is resolved because you predilate, stent, and this is what we have done here. After crossing with the wire, we went with the microcatheter here, inject inside the distal part of LAD in order to be sure that we are in the right position. And you can see here documentation is absolutely confirming a good position. We changed the wire across the microcatheter with the standard wire in order to avoid distal perforation with the stiff wires for like the Conquest. Now we see the predilatation with small balloon, bigger and bigger, and then stent positioning. The other problem here is that first diagonal is involved in the total occlusion. You see that it was involved in the lesion, a tight lesion on the origin. We started after post-dilatation or after pre-dilatation, the diagonal disappeared totally, but we're still seeing something that the origin again here. See that there are some dissection also around the origin of diagonal. We put a wire there, I think. We'll see later now. Yeah, this is the wire inside the diagonal in order to keep it open during stenting in LAD, and then to go to optimize the result after LAD stenting. See now the positioning of proximal stent here, long stent, 3.0 size and 38 I think length. Now you see here we have a good result. The artery here is totally open, but you see that we are still having some disease here and some dissection distally to the stent. This is because I think the diffuse disease in the mid part also of LAD, and I think that if you leave the result like this, even if it's good, but still having poor runoff distally, this might predispose for in-stent restenosis here or in-stent thrombosis. So we decided to complete the stenting here, the mid part of LAD, again with another long stent. And this is what was done. And after that, we crossed the diagonal with hydrophilic wire, dilated both, final kissing, and you see now the result after this. It is good, even if we have some dissection here. The flow is TIMI-3 and no staining of contrast here, so we leave it like this without stenting. And you see still seeing the disease here distally and the dissection, because we haven't stented that yet. Now we decided to put the second stent in LAD. You'll see the second stent here going. This is a second stent, 275 30, and this is the final result. Again, optimization on diagonal. This is the final result. Take-home message is, well, there are some things to do when you are doing, to keep in mind when you are doing CTO. First of all, you cannot give up just after 10 minutes. Every time it's difficult, especially with truly chronic total occlusion. And in these cases, I think the key is to have multiple projection every time and to be flexible also. That means you cannot, there is no rules, fixed rules for CTO. You have to change your strategy during the procedure sometime. I think also the variation of in CTO wires is the key in success here. You have to know how to use these wires.